Remember that childhood ear infection? Or maybe that annoying ache you get with a cold? You just, pop some medicine and mostly it's gone. Simple, right? But what if I told you some ear conditions go way beyond a simple infection, involving something really quite bizarre, biologically speaking, literally skin in the wrong place, and that this misplaced skin can silently, destroy bone? Welcome to the deep dive. Today, we're plunging into a fascinating and, sometimes alarming corner of ear health. We've been handed a stack of sources delving into two complex conditions, cholesteatoma and chronic suppurative otitis media, or C-arm for short. Our mission today is, to unpack these, understand their origins, how they actually impact the body, and what it takes to manage them. We'll pull out the core insights and maybe uncover some surprising details, making sense of what can seem like really dense medical info, sort of a shortcut for you to being truly well-informed.
And it really is a deep dive. We'll be moving from figuring out a strange misnomer to uncovering these surprising bone-destroying processes and critically distinguishing between, what's considered a safe versus a dangerous ear infection. It's far more nuanced than you might first imagine.
I'm already hooked. Skin in the wrong place. That just sounds, I don't know, like something out of a sci-fi movie, honestly. How can something so seemingly, simple be such a big deal?
Oh, it's a very big deal. And understanding the distinctions we're about to explore is absolutely crucial for ear health.
Yeah.
The hidden processes, they can be quite impactful.
Okay, so we've got your curiosity going with skin in the wrong place.
Don't
hit the first surprise right away. The name itself, cholesteatoma. It's actually, completely misleading, like calling a cat a dog, It contains 0 cholesterol crystals, and it's not a tumor despite that oma bit at the end, yet the term has stuck just because it's been used for so long in medicine.
That's exactly right. The real nature of cholesteatoma is, far more intriguing and frankly, a bit disturbing. It really is skin in the wrong place. Specifically, it's keratinizing squamous epithelium. That's the kind of skin lining your outer ear canal. But here, it's found growing actively inside the middle ear or the mastoid bone behind the ear, where it absolutely shouldn't be.
So it's not just a passive patch of skin. It's like a mini factory, pumping out skin cells and debris where it doesn't belong.
Precisely. It's actively growing and shedding. It usually has 2 parts. The matrix, that's the active skin layer making new cells, and then a central white mass, which is just build up keratin debris, shed skin cells. You might sometimes hear other names like epidermosis or keratoma, arguably more accurate, actually.
Right, and that leads to the big question, doesn't it? How on earth does the skin get there? Our sources mention like a whole bunch of theories. Is there a clear answer, or is it still kind of debated?
Well, it's definitely still debated, and that's part of what makes it so fascinating. The real mystery is the origin. It's not just how it gets there, but the sheer number of different ideas. Each paints a different picture of how the body can, mess up. You've got the idea of congenital cell rests, basically. You're born with it, little bits of skin left over. Then there's Whitmack's theory of vagination. The eardrum gets sucked inwards, pulling skin with it. Ruedi suggested basal cell hyperplasia, skin cells just start overgrowing because of infection. Haberman thought maybe skin from the outer ear actually grows through a hole in the eardrum. And then there's Saad's theory, metaplasia, that the middle ear lining itself changes into skin because of repeated infections. It transforms.
Wow, okay, so like 5 different potential routes for skin to end up where it shouldn't. That's a lot.
Yeah.
And I guess these theories tie into how cholesteatomas are classified.
They do, yeah. And the classification is pretty important for understanding what's going on. There are 3 main types. First, congenital cholesteatoma, from those embryonic cell rests. Shows up as a white lump behind a perfectly intact eardrum, usually causes conductive hearing loss. Sometimes it can even burst and start draining, looking like a regular ear infection then. Then you have primary acquired cholesteatoma. This one's tricky because there's no history of ear infections or a hole in the eardrum beforehand. This is where theories like the eardrum getting stuck in invagination of the pars flaccida, that's the top floppy bit of the eardrum, or that basal cell overgrowth idea come in.
So it can just sort of appear without an obvious trigger. That's kind of unnerving.
It seems that way sometimes, yeah. And finally, there's secondary acquired cholesteatoma. This happens when there is already a hole in the eardrum, usually at the edge, a marginal perforation. Here, the theories make a bit more sense, maybe, like skin migrating through the hole from the outer ear canal, or that metaplasia idea, the middle ear lining changing due to constant infection.
It's really fascinating, this whole skin in the wrong place thing, having so many possible backstories. But, okay, regardless of how it starts, once it's there, what happens? What makes it such a problem?
That's the crux of it. The core problem is just the presence of this abnormal active skin. regardless of origin. And that's where the real danger starts.
Yeah.
Because it doesn't just sit there quietly.
Okay, and here's where, like you said, it gets really interesting, or maybe concerning is the better word. Our sources explain that once this cholesteatoma is in the middle ear, it doesn't just expand by, pushing things aside. It actively starts destroying the bone around it. And it's not just pressure doing this, is it?
No, absolutely not. And this is a really crucial point that often surprises people. The bone destruction isn't primarily from pressure necrosis. It's an active process, driven by enzymatic action. Specific enzymes, things like collagenase and acid phosphatase, are released by cells linked to the cholesteatoma. And they literally dissolve the bone. It's not just crowding things out. It's a biochemical attack.
That's wow. A tiny, misplaced skin factory waging chemical warfare on your bones, silently. What kind of structures are most at risk from this enzymatic destruction?
Well, connecting this destruction to why it matters so much, the consequences could be really severe. This enzyme action can destroy the ossicles, those tiny hearing bones. That leads to hearing loss, obviously. It can erode into the inner ear, the labyrinth. That causes balance problems, vertigo, even profound permanent hearing loss. The facial nerve runs through a bony canal right there, too, if that gets eroded. Facial weakness, even paralysis. And maybe the scariest part, if it eats through the bone separating the ear from the brain, the tegmen, tympani, or sinus plate, it can lead to really dangerous intracranial complications, like meningitis or brain abscess.
That is a terrifying thought, seriously. So if it's that destructive, how does it often go unnoticed for so long, just silently causing all this damage?
That's a really critical question, and it leads us right into the next topic. Chronic Suppurative Otitis Media, or CSOM. Because sometimes what looks like just a simple, persistent ear discharge, well, it can actually be hiding that destructive cholesteatoma process, especially if it's the dangerous type of CSOM.
Right, CSM. Okay, so our sources define this as a long-standing infection of the middle ear space. The key features are persistent ear discharge pus, basically, and a permanent hole, a perforation, in the eardrum. And permanent here means its edges are actually lined with skin cells, so it can't heal up on its own, like a little tunnel that just stays open.
Exactly like that. An epithelium-lined fistulous tract is the technical term. And CSOM is, unfortunately, much more common in developing countries, often tied to things like socioeconomic factors, poor nutrition, lack of health education. It's a major cause of hearing impairment, particularly in rural populations. Really highlights its global health impact.
Okay, let's unpack this then. Our sources talk about two main types of CSOM, one they call safe and one dangerous. What makes them so profoundly different?
The difference is absolutely critical. It mainly comes down to the location of the infection within the middle ear, and crucially, whether or not that skin in the wrong place, the cholesteatoma, is involved. So the tubotympanic type is generally considered safe or benign. It involves the front and lower parts of the middle ear near the eustachian tube opening. And it's usually associated with a central perforation of the eardrum, a hole kind of in the middle, not touching the edges. This type has a low risk of serious complications. The aticoenterol type, though, that's the unsafe or dangerous one. It involves the back and upper parts of the attic, the mastoid areas, and this is typically associated with an attic or marginal perforation, a hole right at the top edge or the back edge of the eardrum. And this is one often linked directly to those bone-eroding processes, cholesteatoma, or chronic inflammation called osteitis, or granulation tissue. High risk of complications here.
So just the location of the hole in your eardrum can tell you a huge amount about how dangerous the underlying infection might be. That's a really vital distinction. Okay, let's dig into each type a bit more. Starting with the tubotympanic, the safe kind. Sources say it often starts in childhood. Maybe after a bad ear infection, like with measles, or infections spreading up from the tonsils or sinuses. And surprisingly, sometimes even allergies, like to milk or eggs, can cause persistent discharge.
Yes, that's right. And pathologically, in this safe type, the disease tends to stay confined to the mucous membrane, the lining of the middle ear. You'll typically see that central perforation varying in size. The lining itself might look normal, or it could be swollen, red, kind of velvety. Sometimes pale, mucus-filled polyps might poke through the hole. Now, the hearing bones, the ossicles, are usually intact, but the long part of the incus one, the key little bones, can sometimes get eroded over time. You might also see something called tympanosclerosis, white, chalky deposits on the eardrum or in the middle ear. These don't always cause issues, but if they build up, they can stiffen the eardrum or ossicles and cause conductive hearing loss.
And the symptoms sound pretty distinct, too. The discharge isn't usually foul-smelling, more clear or slightly cloudy, mucoid, and it comes and goes, maybe flares up with a cold or if you get water in the ear. Hearing loss is usually conductive, not too severe. But then there's this really weird paradoxical effect mentioned. Some people actually hear better when the ear is discharging fluid than when it's dry. How does that even work? It sounds completely backwards.
It absolutely does. It's one of those fascinating little quirks. It's called the round window shielding effect. Basically, the fluid in the middle ear helps maintain the proper phase difference for sound waves hitting the two inner ear windows, the oval window and the round window. In a dry ear with a perforation, sound can hit both windows almost simultaneously, which can actually dampen the vibration and make hearing worse. The fluid sort of corrects that. Treatment for this safe type is mainly about controlling the infection. Thorough cleaning, what we call oral toilet, maybe suctioning, dry mopping. Antibiotic eardrops are key, sometimes with steroids, although you have to be a bit careful about potential side effects like skin irritation or, rarely, inner ear toxicity. Systemic antibiotics might be used for bad flare-ups. And keeping water out is crucial. Avoid swimming without protection, careful showering, no forceful nose blowing.
Okay, that makes sense for the safe type. Now let's switch gears to the dangerous one, the adipometral type. Our sources say this is basically the same disease process as cholesteatoma, often seen in ears where the mastoid bone is dense, sclerotic. What are the key pathological differences here? What makes it so dangerous?
Well, here, the pathology is really defined by that cholesteatoma, or by chronic bone inflammation, osteitis, and granulation tissue that's like scar tissue trying to heal, but it can become bulky and problematic. You can form fleshy red polyps. And acicular necrosis, damage to the hearing bones, is way more common and usually much more severe than in the tubotympanic type, leading to greater hearing loss. But then you get this other really bizarre twist, the cholesteatoma hearer.
Wait, what? A cholesteatoma hearer?
Yeah, it's shocking, right? This is where hearing can actually be surprisingly normal or near normal because the cholesteatoma mass itself forms a kind of bridge. It fills the gap left by the destroyed ossicles and transmits sound vibrations across. It's like the disease accidentally fixes the hearing loss it caused. Temporarily, at least.
That is truly wild. A destructive thing that can, in this weird way, actually help hearing sometimes. Okay, what other signs and symptoms should really set off alarm bells for this dangerous type?
The discharge is often a key clue. It might be scanty, not much of it, but it's frequently foul smelling. That smell is a sign of bone being destroyed by bacteria and the cholesteatoma's enzymes. And here's something really crucial for people to understand. If an ear that has been draining suddenly stops, that's not necessarily good news, especially with this type. It could mean the pus is trapped inside, building up pressure, and it might be finding another way out, like inwards, towards the brain or inner ear. That's a serious warning sign.
Right. That makes sense. A sudden stop in discharge could be really bad. What about things a doctor might see when looking in the ear?
Yeah, a key diagnostic feature is the retraction pocket. This is where the eardrum gets sucked inwards, usually in that upper back area, the attic or posterior superior part. Our sources describe these pockets progressing in stages. Stage 1, just a slight dimple. Stage 2, it touches the incus bone. Stage 3, called atelectasis, the drum is draped right onto the inner structures. The middle ear space is gone, but the lining is still there. You might even be able to lift it slightly with suction. Stage 4 is adhesive otitis media. The drum is plastered down, stuck, no middle ear space left at all. And the critical thing is these deeper pockets, especially stages 3 and 4, are perfect places for skin debris to collect. They can trap keratin, and that's often how an acquired cholesteatoma forms. Sometimes you can literally see pearly white flakes of cholesteatoma debris in these pockets or suction them out.
Okay, so putting this all together, what does it really mean for someone experiencing these symptoms? Why are details like a foul smell or that weirdly good hearing or seeing a retraction pocket, why are they so incredibly critical to pay attention to?
Well, what's really striking here is how these subtle signs can actually point to really significant, potentially dangerous processes happening hidden inside the ear. That progression of retraction pockets, for instance, it really shows how the body's attempt to maybe wall something off can ironically create the perfect environment for a more dangerous condition like cholesteatoma to develop. It means any persistent ear discharge, especially if it's foul smelling or any sudden change in hearing or dizziness, it all needs serious medical evaluation. You absolutely cannot just ignore it or hope it goes away.
And that leads directly to the complications, right? Especially with the adipometral type or any cholesteatoma, the stakes are just so much higher. Our sources are really clear. Pain isn't typical in simple chronic ear infections. So if pain develops, that's a major red flag. What are some of the specific severe complications we really need to highlight?
Absolutely. These are the warning signs that mean things might be getting serious, needing urgent attention. Pain, as you said, could indicate infection spreading outside the ear, maybe an abscess forming near the brain, or inflammation around the major veins. Vertigo, feeling dizzy or off balance, suggests the cholesteatoma might be eroding into the inner ear balance canals. That could lead to labyrinthitis, severe inner ear inflammation, or even meningitis if infection spreads further. A persistent headache is always worrying, could point to an intracranial complication. Facial weakness, drooping on one side. That suggests the facial nerve canal is being eroded. Potential paralysis. In a child, being unusually listless, not wanting to feed, sleeping too easily. That could actually signal an extradural abscess, pus collecting just inside the skull. Fever, nausea, vomiting, classic signs of potential intracranial infection. Irritability, neck stiffness. Meningitis alarms should be going off. Double vision. Could be Gradinego syndrome, affecting nerves deep in the skull base due to infection spread. Unsteadiness, ataxia. Could be labyrinthitis again, or even a cerebellar abscess in the back of the brain. And of course, an obvious swelling or abscess behind or around the ear points to mastoiditis, infection spreading in the mastoid bone. All of these demand immediate medical help, no waiting.
That is a truly terrifying list of possibilities. Okay, so given these really serious risks, what's the main way to treat adicolorental CSM and cholesteatoma? It sounds like surgery is pretty much the only real option.
It really is the mainstay, yes. The absolute #1 goal is to remove all the disease, the cholesteatoma, the infected tissue, and make the ear safe from those complications. The secondary goal is, if possible, to preserve or reconstruct hearing. But, and this is crucial, never at the expense of safety, eradicating the disease comes first. And there are basically two main surgical philosophies or approaches, and they come with significant trade-offs that patients really need to understand.
Right, I saw that. The canal wall down or CWD procedures versus the canal wall up or CWU procedures.
Yeah.
Can you break down how they compare and what those big trade-offs are?
Sure. Canal wall-down procedures essentially involve removing the back wall of the ear canal, opening up the mastoid cavity, that honeycomb bone behind the ear, so it becomes one large space connected to the external ear canal. Think of it like taking the wall down between two rooms. Examples are modified radical or radical mastoidectomy. The big pro is that it fully exteriorizes the whole area where disease might hide. This means there's a very low rate of cholesteatoma coming back or being left behind. So it's considered a very safe procedure in terms of getting rid of the disease for good. The cons, however, can significantly impact quality of life. You end up with a large open ear cavity, the meatus. This cavity often needs lifelong, regular cleaning by a doctor to remove debris and wax. Fitting a hearing aid can be tricky, and water activities like swimming are usually restricted because the cavity is prone to infection if it gets wet.
Okay, so safe from disease recurrence, but maybe less convenient day to day. What about the canal wall up approach? Sounds like it tries to avoid those cavity problems.
It does. The goal of CWU procedures is to remove the cholesteatoma and disease while preserving that posterior bony ear canal wall. So you keep the normal anatomy of the ear canal intact, no large open cavity. The pros are pretty attractive. The ear looks normal from the outside. It generally doesn't require that routine cleaning. It's much easier to reconstruct the hearing mechanism later, and there are usually no restrictions on swimming or other activities. But the major drawback is a significantly higher rate of recurrent or residual cholesteatoma. Because you're working around corners and keeping the wall up, it's harder to be 100% certain all the disease skin has been removed. This means patients need very long-term follow-up, often with imaging like MRI. And frequently, a planned second-look surgery is needed, maybe 6 to 12 months later, just to go back in and double-check that no cholesteatoma has regrown.
Wow. So it really is a complex decision. You're trading off maybe a lower risk of recurrence with the CWD against potentially better hearing outcomes and convenience with the CWU, but with that need for vigilance and possibly more surgery.
Exactly. It's a very nuanced discussion between the surgeon and the patient, weighing the extent of the disease, the patient's lifestyle, their ability to attend follow-up. There's no single right answer for everyone. And conservative non-surgical treatment, it really has a very limited role. Maybe for a tiny, easily reachable cholesteatoma in someone who can come for frequent cleanings, or perhaps in someone very elderly or too medically fragile for major surgery, but it requires constant monitoring.
It's just incredible, isn't it, how many different underlying things can cause these chronic ear problems. We think ear infection, but it could be this weird skin growth, or even tuberculosis or syphilis.
Yeah.
Our sources touch on tubercular otitis media briefly.
Indeed. It's less common now, but still important. Tubercular otitis media is usually secondary. The TB bacteria spread from the lungs, typically via the eustachian tube or sometimes the bloodstream. More often seen in kids or young adults in areas where TB is prevalent. Clinically, the surprising thing is often painless ear discharge, even though it might be foul-smelling because there's often bone destruction involved. And a really classic sign, something for you to remember, is seeing multiple perforations in the eardrum. maybe 2 or 3 tiny holes, which might eventually merge into one bigger one. Hearing loss tends to be severe, and facial paralysis is unfortunately quite common with it too. Diagnosis can be tricky because it can look like regular CSOM. You often need specific tests looking for TB bacteria in the discharge, maybe a biopsy, chest x-ray, DNA probes. Treatment is primarily antituberculosis medication. Surgery is usually only for complications, and after the TB treatment is well underway because healing can be really poor otherwise.
Wow, painless discharge and multiple holes. Key clues there. And then even rarer, syphilitic otitis media.
Very rare these days. Here, the Syphilis spirochaete bacteria reach the middle ear. The key impact, though, is often on the inner ear. It invades the hearing and balance organs and nerves, causing profound sensorineural hearing loss, tinnitus, vertigo. You could also get bone destruction and foul discharge, like in other severe ear infections. Diagnosis needs specific blood tests for syphilis, like FTA-ABS. And treatment is, of course, antisyphilitic therapy, usually penicillin, along with local ear care. It just goes to show, doesn't it? The ear is so intricately connected to the rest of the body, you always need to think broadly.
What an incredible journey we've taken today, seriously. We started with that mind-bending idea of cholesteatoma's skin in the wrong place. We unpacked its debated origins, discovered its sneaky enzyme-driven bone destruction, then navigated the whole world of chronic suppurative otitis media, CSO. Learning the vital difference between the safe tubotympanic type and the dangerous atacoantral type, which is so often linked with cholesteatoma, we explored those really complex surgical choices, balancing safety against quality of life, and even touched on surprising systemic causes like TB and syphilis hiding behind an ear problem.
Yeah, and I think the key takeaway for you listening is just how important it is to recognize the signs, even the subtle ones. That persistent ear discharge, maybe that slight change in hearing, that occasional dizziness. It might not just be a minor annoyance. It could genuinely be a symptom of something much more significant happening inside, something that needs proper attention. What seems like a simple earache might mask a condition that could be, well, truly life-altering if ignored.
It really makes you wonder, doesn't it, how this tiny, often overlooked space, the middle ear, can become the stage for such a complex battle. You've got normal tissues invading skin cells, the body's own inflammatory response, misguided healing attempts, all fighting it out. What other silent processes might be unfolding inside us, just waiting for us to take a deep dive and really understand their hidden complexities? Something to think about. That's all for this deep dive.